This is a case of 57-year-old female where there is a L4-5 lytic listhesis, this is a L4 lysis, and this is a grade 1 to grade 2 listhesis. She is having bilateral lateral recessed stenosis on L4-5. There is a sacralized L5, that's why they have labeled it as a L3-4, but this is a second last mobile level where we are going to do the transforaminal lumbar interbody fusion. For this case, we are using the percutaneous pedicle screws, which we are going to demonstrate. This is a L4 vertebra. These are the pedicles. These are the transverse processes. So one should be able to clearly visible pedicles and transverse processes. Sometimes transverse processes are not visible, that's okay, but vertebra should be squared so that we should be able to see the proper pedicles. So on skin, incision will be at the tip of the transverse process on an average. There is no thumb rule. One can go little lateral if patient is obese, one can go little medial if patient is thin, or one can decide the incision if one is going to do the tubular T-leaf where incision is going to be here. I have taken a 15 number knife and I am checking it on Siam where I am. So we are going to take the incision at the tip of the transverse process for L4 pedicle. This is around 1 centimeter incision. To avoid oozing, I am going to do the little bit of dissection with monopolar cautery. After that, I am going to confirm it whether I have cut the fascia or not with the finger dissection. I can feel the transverse process and the facet. This is a cannulated needle from which guide wire can go once it is in pedicle. Shoot. 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 So I am on the lateral border of the pedicle at the center on Siam. So I am going to tap it with hammer. Shoot. 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 Go till the medial border of the pedicle and then take lateral. Don't cross the medial border of the pedicle in AP view so that you can avoid breaking the pedicle. So we need to confirm in lateral now that we are entering into the body and we are still not into the pedicle. So I have reached till the medial border of the pedicle now in AP view. Now I am going to take a lateral view to confirm whether I am in a pedicle or I am in a body. Now in AP view, my needle is already touching the medial border of the pedicle, and in lateral view I have already crossed the pedicle and I am already into the body, so I am safe. If my needle is touching the medial border of the pedicle and in lateral view if I am still into the pedicle, that means I am going to break the medial all of the pedicle. In that case, we have to decrease the medial angulation and relocate the needle. Now this is guide wire being placed through that cannulated needle, and we can put this guide wire till the anterior cortex of the vertebral body. While removing the needle, one should hold the guide wire so that it should not come back with the needle, and we can keep it aside till we do the interbody work. So I have inserted first guide wire which we demonstrated, then all other 3 needles I have already inserted, and I have stopped in AP till the medial border of the pedicle in all 3 needles, and in lateral view all 3 needles are already crossing the pedicle and they are already into the body, so this is safe. If one is touching the medial border of the pedicle in AP view, but in lateral view if needle tip is here, that means that guide wire or needle is very lateral. One should do the more medial angulation. If other way around, if in AP view guide wire is or needle is at the middle border of the pedicle, and in lateral view if it is in a pedicle only, not entering into the body, that means one need to decrease the middle angulation and one should reach in the body, so that one should not break the middle wall of the pedicle. All 4 guide wires are placed in lateral view also, they are perfect. They are not reaching till the anterior border of the body, so they are being seen till the middle border of the pedicle. That's okay. When we are going to tap, we are going to advance the screw, so screw will be seen little medial to the middle border of the pedicle. One should be careful while putting the guide wire through the needle in osteoporotic bones, otherwise it breaks the anterior cortex very easily and it can pierce the anterior wall and can go into the anteriorly, which is not safe. All 4 guide wires are placed, and while doing the interbody work you can attach those guide wires to the drapes with artery forceps, so that they are not going to come in your way while doing the interbody work. You can put the gauze piece, which is a radio opaque, into those incisions to avoid the oozing, like this, and you can keep it like that till you are going to insert the pedicle screws on those guide wires. We have done the interbody work and decompression through this midline 2 cm incision. It is an incision as good as we take for the microdiscectomy, and now we are going to close it and going to put the pedicle screw through this guide wires. C-arm is in a lateral position, and everything needs to be done in a lateral position only now. I mean C-arm needs to be in a lateral position only. These are the sleeves. This is the first sleeve. By rotational movement you need to insert it till the lateral border of the facet. Then second sleeve, then third sleeve. Everything goes on the guide wire now. Then one need to remove the first sleeve and tap the pedicle. Now we are going to put the 6.5 mm pedicle screws. I am tapping it with a 4.5 tap. One can tap it with a 5.5 mm tap also. There is no need to see tap on C-arm. On an average you can tap the pedicle like till the 30 to 35 mm. Then one should hold all the time guide wire so that it should not come back with the tap. Once tap is little bit out, you can rotate it with the hand so that it is easy to remove, and I am holding the guide wire all the time so that it should not come back. Now the second sleeve is also removed and the screw is being placed on the guide wire. Once you feel it is inadequate, then you can take a shoot screen dakho, and you can see how much it is going in. Once screw crosses the pedicle in lateral view, you can remove the guide wire you can advance the screw by observing it on the C-arm lateral shoot. That looks good. So detach the handle of the screw and keep that sleeve of the screw in place for putting the rod. Now both screws are inserted on the left side. Guide wires are removed. This is a instrument on which you can measure the length of the rod, and accordingly you can take the rod. They are already pre-bent little bit, and there is a handle to attach it, and you can insert it from above down or below up. So I prefer to insert it from above down. It should go below the fascia, so you can remove the C-arm and you can put it under the vision. Now rod is inserted from proximal to distal direction or cephalad to caudal direction. It is confirmed on the C-arm on lateral view. all the time C-arm is in a lateral view only. Now I am putting the knees. Both knees are placed, but they are not final tightened. I am removing the handle of the rod and then final tightening of the knees with the help of torque limiting screwdriver. Hold it. We have confirmed that rod length is adequate. Both the knees are properly tightened with torque limiting screwdriver. Now there is an instrument to break these sleeves. Left side screws and rod are already placed. Now I am putting the right side screws from the left side only. There is no need to go on the right side because all the time I need to see the screen of the C-arm image intensifier. So I am standing on the left side only and screen is on the right side. So I am going to put the right side pedicle screws from left side only. Now both right side pedicle screws are placed. But to put the rod, I need to come on the right side. It is not possible to put the rod from the left side. So I am going to come from the right side and then going to put the rod. While putting the rod should go below the fascia which is in between the two screws. So while inserting it, tip should go below the fascia and then you should insert it. You can confirm it under vision whether it is coming through the second sleeve, or there is one instrument to confirm it whether it is into both the screws or not. Side rod is inserted by my assistant standing from that side because I was standing from this side. Now if you see on the C-arm, both rods are overlapping, so we cannot confirm the length. So to confirm the length, one can elevate this end of the C-arm and take the oblique view. वरती करा आणखी जरा. हाँ बस. Now shoot. Now we can see the two rods in this image, one which is already being fixed and the other one which we are fixing now. So by doing this you will be able to see the two rods and confirm the length. Now this is just before closure. These are the 4 incisions of the 4 pedicle screws. This is a midline incision. One can call it as a hybrid T-leaf as we have done interbody work and decompression through this midline incision. If one wants to do tubular T-leaf, then these incisions can be little medial, and on C-arm they can be on the lateral border of the line of the lateral border of the pedicles. So one can change these incisions accordingly the way one wants to do the interbody work. Final fixation: 4 pedicle screws, cage in the center, that's on the lateral image, well placed pedicle screws, interbody cage of 13 mm, and listhesis was already reduced on the position only. So that's the final fixation. In video it looks complicated, that so many shoots and guide wires and needle, but in practical it is very easy to do this. Single level T-leaf can be finished with these percutaneous pedicle screws in 1.5 hours, skin to skin, and with this you can avoid lot of dissection, lot of blood loss and struggle while putting the open pedicle screws. It is very useful specifically when you are doing the L5S1 lytic listhesis, where L5 is very deep seated and it is very difficult to find out the entry for the L5 pedicle. And it is not compulsory that if you are doing the T-leaf that you should use the tubes. By doing this hybrid technique, one can do the T-leaves with regular loops. There is no need of microscope also, and over a period of time one can shift on the tubes also.